Okay. So, welcome everyone. I'm happy to see you here. Thank you for joining us on a Saturday. I know it's not ideal, but this accommodates everyone's time zones as best as we can. I'm happy to welcome you to our fifth Pathology Resident-Led Live Unknown Slide Session, or PRLUSS, as I like to call it. Today's topic is going to be endometrial carcinomas, presented by dear friend Wangpan Jackson Shi. He is a PGY2 APCP resident at the University of California, San Diego, and he has picked some very interesting and illustrative cases for us, which we are all very excited to see, of course. First of all, a few housekeeping items. Updates regarding future sessions are going to be made mainly through my Twitter account and KiKo account. You can find all of the info in this regard in the info box of the video. We also have a Twitter group, so if you want to join it, don't hesitate to contact me. DM me on my Twitter account. It's listed on the screen right now. And as I said, you can find everything in the description of the video. The sessions are recorded, so you can watch them on YouTube afterwards. And actually, a bit for those joining us for the first time, what are these sessions? They're actually a pretty new project of mine, created with the intent of offering pathology trainees all over the world the opportunity to come together online and learn pathology from one another, while at the same time exercising our presentation skills in a very informal and benign and welcoming environment, as I hope you'll notice throughout the session. So I encourage each and every one of you to reach out, volunteer to present in one of our future sessions. My contact info, like I said, is should be displayed on the screen right now, can also be found in the info box. And spread the word so that everyone can hear about this great community of ours and potentially join us. So yeah, without further ado, I am now going to pass the microphone to Jackson. So a second. Let's stop sharing. Yes.
All right. Good morning, good afternoon, or good evening, everyone. Thanks for joining us, and thank you, Marina, for organizing this event and inviting me and the kind introduction. And let me share my screen. All right. Do you guys see it okay?
Yeah, it's visible.
All right, cool. So today I just want to share some cases about endometrial carcinoma. This mean to be very basic and to help us as a trainee to understand the classic morphology of different endometrial carcinoma, and hopefully everyone we can learn together. So as Marina introduced, I'm a PGY2 at UCSD, and my interest in gynecologic pathology. So, basically, before that, the categories of endometrial carcinoma includes endometrioid carcinoma, the serous, clear cell, and mixed carcinoma. I'm not gonna show some cases together today, but there are other differentiated carcinoma, undifferentiated carcinoma, or Mesonephric-like carcinoma. And the last category is very rare, which is Meusner's carcinoma of gastric intestinal type. Sometimes like morphology is very important and make people favor one endometrial carcinoma versus another one. But at the same time, we need to incorporate immunoprofile, immunostains, and sometimes you need molecular classification to kind of guide the treatment and guide the prognosis of the tumor. But that's beyond the topic of my talk today. So let's get to the case one. So it's a 64-year-old female with abnormal uterine bleeding, and they found a mass. And here is a gross picture. So The section I'm showing here is the deepest invasion of the mass to the myometrium. As you guys can see, it's a quite heterogeneous mass. There's some white or yellowish area, kind of lobulated, and there's some dark, possible hemorrhagic area. And that's a gross photo of this mass. And then let's get to the H&E session. So low power field. It shows a kind of mixture of some glandular structure and intermingled with some solid areas with this glandular area. And also at the right part, you guys can appreciate this large area of solid uh, tumor cells, which somewhat shows some clear looking, which is not very apparent on the low power. Then let's zoom in further to the glandular area. So from this field, you guys can see there's some glands forming here, but at the same time, there's some spindle cell, pretty solid. And you might wonder, is this endometrial stroma cell or is this a part of the tumor? And there's some lymphocytes like throughout the lesion. So further zooming of the spindle cell or solid area, we can see the cell kind of relatively monotonous, shows some vesicular nuclei and some conspicuous nucleoli. But overall, it's not very pleomorphic. There are some bigger cells at the left lower part here. Then let's switch gear to the large solid nest of this clear cell looking area. So basically these cells with some clear cytoplasm, but the nuclei are pretty monotonous and they're forming this solid nest with some central possible necrosis or some abscesses. We can see some neutrophils in the center. So further, this solid area shows basically the same morphology of cells, some clear cell looking and with some central punctuated necrosis or abscesses. Another area of this tumor shows somewhat clear cell of the cytoplasm, but somewhat pinkish, and people may wondering, is this squamous looking or squamous differentiation? Then that's very focal area we identified in this tumor. So that's a whole spectrum of this entire lesion. Basically, you have a glandular architecture, you have some intermingled spindle or solid cell looking, and there's some solid nests with some clear cell or possible squamous morphology. So let's open the first poll. What's your impression on this lesion? Is this a serous carcinoma? B, is this a clear cell carcinoma? B, or you think it's an endometrial carcinoma? Or it could be an endocervical adenocarcinoma. E, like you need further IHC immunostains. So I will give people a minute or two to pick one, and then you can put in the chat box or feel free to open the mic and discuss.
People are shy.
Don't be. This is supposed to be learned together. It's like Miruna said, this is just a discussion, and we're all learning this thing together.
I think you can tell us the answer now.
Cool. So yeah, you are perfectly right. This is an endometrial carcinoma, and I'm gonna show some annotations. First of all, why is endometrial carcinoma? It's this clear cell looking. It's a squamous differentiation, but it's basically the glycogenated like squamous cell makes a clear cell that mimics the clear cell carcinoma, but this is actually the glycogenated squamous cell with this distinct vacuole. And another feature favor this being an endometrioid type because this has smooth luminal border, which is different from a serous carcinoma. I will talk about that later. So basically, the lumina are pretty smooth, and the nuclear are kind of columnar and a little bit pencilated, but not to the tuber adenoma. But you can appreciate the morphology. And then we have these areas of cribriforming glands. Basically, the glands are kind of connecting with each other together to forming this cribriform morphology. Those are the three important features in this case by morphology to favor endometrial carcinoma. But as I said, like nowadays we need immunostains to rule out other possibilities because morphology is important, but immunos need to confirm and rule out other differential diagnosis. So for this case, the P53 is normal expression, wild type, and MH1 and PMS2 are intact, but MSH2 and MSH6 are lost. In this case, it's positive for ER/PR, negative for naphthalene A, and negative for P16. And a quick summary of the immunostain we did here. So P53 basically to essentially to exclude serous carcinoma. So if you have a positive or abnormal P53, that does not necessarily mean it's serous carcinoma. But if P53 is negative, that essentially rule out serous, high-grade serous carcinoma. And there are some very few reported P53, TP53 null mutation. Sorry, TP53 null serous carcinoma reported, but that's exceedingly rare. And for MSI, basically, if you have an abnormal MSI profile that strongly supported endometrioid carcinoma, and for a endometrioid carcinoma, you should have ER/PR positive, uh, unless if you are having a high-grade serous or endocervical or Mesonephric-like. Those type of endometrial carcinoma tend to have negative ER and PR. For P16 here, it's helpful to exclude endocervical origin or its high-grade serous carcinoma can have very strong P16. And napsin A, of course, people aware that's a general marker for clear cell carcinoma, as in this case, there is some clear cell looking, but that's not the right architecture for clear cell carcinoma. So the final diagnosis is endometrial carcinoma, FIGO grade 3. Basically, we have more than 50% of solid area. So let's talk about the differential diagnosis by morphology. Basically, for glandular components, the differential diagnosis of endometrioid is serous carcinoma, endocervical adenocarcinoma, and the Mesonephric-like adenocarcinoma. All of these three can show some glandular component. Again, this needs to be excluded by both morphology and immunoprofile. And for a solid or spindle cell component, this could be a FIGO3 endometrioid, or this could be a serous dedifferentiated carcinoma, or endometrioid carcinoma with some spindle cell growth. So again, this is a kind of the combination of morphology and immunostains to rule out like serous carcinoma or dedifferentiated carcinoma, which I'm gonna show it later in some cases. So this is a classic like I was told like what is the endometrial morphology? By low power, you should recognize this because they have smooth luminal border. This is a glandular or villo-glandular, but the border is smooth. There's no like complex arc papillary architecture. There's no tufting, no micropapillary. So this is by architecture, this is the endometrial morphology. And by cytology, the endometrial morphology compared to Serous, you have relatively monotonous nuclei, and the cells are more columnar. The cells can be vesicular with some nucleoli, but you don't see the macronucleolus. That can be a feature for serous carcinoma. And again, the luminal border are pretty smooth. So here's another picture of endometrial morphology. This is more like you see some glands, but they're like kind of poorly formed and they are transitioned to a more solid area. But within this solid area, you may not be able to recognize the endometrioid morphology. But with this area of glands, that's pretty helpful for you to say, oh, this possibly this is a FIGO 3 endometrial carcinoma, but you need to do stains to support your diagnosis. And another picture of endometrial morphology, basically this gland, smooth luminal border, and the nuclear not very pleomorphic. They're monotonously atypical, and there is some mitosis in this case, but still, like you don't see the significant atypia in serous carcinoma. Then, on the contrary, what is classic for serous morphology? Basically, this is from low power. You're already appreciated like there are some glands, but the glands are pretty irregular. They're called like slit-like luminal space. They're irregular, and there's some possible micropapillary or tufting in the gland, and they're forming kind of complex papillary structure maybe in this gland. So this is kind of a low power morphology or impression. This could be a series, but you need to look at the high power field to look at the cytology, which in this case, uh, first of all, the nuclear become vesicular, and you appreciated like the nucleolus, and there are conspicuous mitosis, which I think the next picture shows more mitosis. But by this looking, this is a bona fide like high-grade serous carcinoma. This picture shows like you guys can appreciate there's some mitosis here, and the cells are kind of pleomorphic. They're big. They have nucleolus. Uh, they're pleomorphic. So the final picture for the series morphology, this aimed to show this macronucleolus in the tumor cells, and in addition with the architecture of irregular luminal border in this gland. So this by morphology, this makes it a serous carcinoma. So to summary of the image gallery I just showed, so general morphological features favoring endometrioid, you have a smooth luminal border, you have glandular cribriform architecture, like the glands forming cribriform pattern, and you have squamous differentiation. But imagine if you have a solid high-grade tumor with some overlapping morphology and immunoprofiles. The only thing that can make you favor is endometrial carcinoma by morphology is actually squamous differentiation. Uh, so for general morphological features favoring a serous carcinoma, so generally you have more irregular luminal border, you have some advanced architecture like micropapillary, papillary architecture, some complex intraglandular structure. And this is more like low power field. For high power field, you're gonna see the high-grade cytology that is defined by mitosis, nuclear membrane irregularity, pleomorphism, and loss of nuclear polarity. So with this kind of background information, let's get to case two. So it's a 73-year-old female with an endometrial mass, and this is a low power field. And then you're gonna say, well, there's some papillary growth. This is kind of exuberant papillary. There might be some micropapillary, and I'm not sure I'm seeing any glandular structure here. This is more like papillary structure, and this seems to be like on the surface, not really invading to the myometrium here. Then zooming of this area, the lumen become quite irregular. They have this like advanced papillary structure or even micropapillary in some areas. So then you want to see, let's look at the cytology further. So zooming further, so the nuclei are not that strikingly pleomorphic, but they're atypical and they are become vesicular. They have some nucleolus. I'm not seeing much mitosis here. but there might be some dark hyperchromatic cell on the left corner. It looks kind of pretty atypical. So this makes you feel, oh, this is a serous carcinoma. But at the same time, on the right part of the imaging, you see some pinkish, possible or equivocal squamous differentiation, or it's just the cell become pink, like metaplastic changes. But then another field of this tumor, we see some much more possible. The cytoplasm become more pinkish, more squamoid looking, but at the same time, the cell become ugly, become high grade. So here is a different section for the same tumor, but it's more invasive area from different section. So at this low power, we start to appreciate, oh, there's some glandular formation. They're not much smooth, but they have the morphology of endometrioid morphology. And then zooming of the cells, like, oh, they're not very pleomorphic. They are monotonous. They don't see like macronucleolus. I don't appreciate any convincing mitosis here. That might be one here. So then you are in a stock. So another picture of the invasive section, you're gonna see more of this pinkish, possible equivocal squamous differentiation, or it's just because metaplastic changes. So last picture of the this tumor session, it's become more solid area and the cell become kind of ugly again. You starting to see some nucleolus and there's some glandular area. So basically, this is a case with more ambiguous or mixed morphology. And then I'm gonna show you just the one stain, which is P53. This is a P53 for the areas shows more papillary area. So you guys can see the internal control of the stromal cell or lymphocyte are positive, but the tumor cell are deadly negative, which is compatible with a null type of abnormal P53 stains. And another section shows a more glandular area of this tumor is deadly negative for P53. So with all this information, let's open the pool two. So what's your impression on this tumor? This is a straightforward serous carcinoma. B, this is a mixed serous endometrial carcinoma. C, this is endometrioid carcinoma with aberrant P50 expression. D, you need further immunostains to support your impression. Let's hear what people say.
I personally would want more stains.
Yeah, I agree. It is ambiguous. It's not straightforward as the first case. Yeah, but there are some morphology features that can help you, even in the controversial area.
I mean, if I would have had definite squamous metaplasia, as in you could have taken a photo of it and put it in an atlas and said, yeah, this is squamous differentiation, then maybe I would have said, okay, it's endometrioid. But with that morphology, maybe
Right,
additional
I
stains are
agree.
needed.
I agree. Exactly. So basically that's what we did as well. So let's look at the furthest thing first and then decide what's the diagnosis. So we did additional immunostains in this case. So basically, in both of the area, both sections, the tumor are positive for ER. PAX2 is patchy positive, and they show convincingly Peton loss. I wish I have the stain, but the case was filed. I don't really have the access to that, but Peton is convincingly lost, like absent in those areas. And creatinine is negative. P16 is patchy positive in both sections. TDF1 is focally positive. GATA3 is deadly negative. MMR is intact. So, with this immunoprofile, so that actually brings us another topic. So, what immunostains can help us to favor this is endometrioid versus others? Apart from mismatch repair protein MMR, there are some other biomarkers proposed, like including P10, PAX2, or beta-catenin. And if you have abnormal pattern of P10, which is loss, if you have loss of PAX2, or you have nuclear expression of beta-catenin, that favors the diagnosis of endometrioid adenocarcinoma. And some authors may propose ARID1A, but we don't use it in our institution. So with this immunostains and the morphology features equivocal or possible squamous differentiation, so the case was signed out as endometrial carcinoma with endometrioid features, FIGO grade 1. And to summary of the things, tumor shows extensive papillary growth with areas of squamous differentiation. Although the findings are somewhat ambiguous, as we illustrated, the invasive carcinoma is high-grade endometrial, and both the morphology and certain immunophenotype features suggest an endometrioid differentiation, including the squamous changes by morphology. So, from this case, basically, abnormal P53 does not equal to serous carcinoma, as like 20% of high-grade FIGO grade 3 endometrioid carcinoma can have mutation pattern of P53. So we should never rely on one stain or one morphologic features to give a diagnosis. It's a comprehensive work to incorporate everything together. So with that, let's look at case 3. So it's a 71-year-old female with abnormal uterine bleeding. So low power field, we start to see there is a huge area of necrosis. And for the tumor itself, architecturally, there are some glands, but they're irregular. They have this tufted structure, and this part is more solid sheets. But at this power, we can appreciate some hyperchromatic cells. And then let's zoom in further. So this picture, we can see the tumor nucleus, pleomorphic. There are some pleomorphic cells, and the cells become very vesicular, very macronucleolus, and in arranging the solid sheets appearance. Further of this section shows like somewhat glandular formation, but they're not perfect. But we can appreciate the pleomorphic cells and hyperchromasia in this nuclei. This again to show the macronucleolus in the tumor section and become very kind of uh solid pattern. You don't really see glands, you don't really see papilla. It's just a solid morphology. So with that, let's open post 3. What is your impression on the tumor? A, it's a serous carcinoma. B, it's a FIGO grade 3 endometrial carcinoma. C, it's a dedifferentiated carcinoma. D, it's a lymphoma. So before looking at the immunostains, what do you guys think? Any idea? Oh, sorry.
You gave us a sneak peek.
Yeah, I was trying to look at the chat box.
The differential is definitely good in the sense that this is a common struggle if you do GYN pathology, FIGO grade 3 endometrioid carcinoma versus serous, because we know serous carcinoma can show the so-called pseudoglandular pattern, which is even more deceiving. And like you pointed out, the morphology is very important, and especially the cytomorphology is what gives you a hint towards one or the other. With serous carcinoma losing nuclear polarity, showing those bigger nuclei, even in the pseudoglandular pattern, when the nuclei are bigger and they tend to lose polarity and reach toward the apical portion of the cells, it's another indication of a serous morphology. As you said, also the smooth luminal borders and stuff like that. But even if you might think, what's dedifferentiated carcinoma has to do here in the differential? And it has, because even with undifferentiated, so purely undifferentiated carcinoma. Serous carcinoma can be in the differential diagnosis. The so-called solid type serous carcinoma can come in the differential. Lymphoma, not that much, because lymphoma would grow very discohesively, you know, more likely with an undiff carcinoma. But all are great differentials, and I see Alem already said it's a serous.
Yeah, good job, Ellen. Yeah, it's a serous carcinoma by morphology. And so, yeah, nice summary, Miruna. Yeah, that's some of the consideration when you look at uh, this type of morphology. So let's look at the immunostains. Basically, in this tumor, P53 is abnormal expression, overexpression, and MMR is intact. Paxate and keratin is positive. And the important thing about Paxate and keratin is in a dedifferentiation or undifferentiated carcinoma, in that setting, you won't have that strong keratin and strong Paxate. And uh, okay, so the final diagnosis is high-grade serous carcinoma. This is to aim for us to look at the classic morphology and to do the right immunostains and to exclude other things, and then we can call it. So let's jump to case 4. It's a 70-year-old female with a uterine mass. Then this is a low power field of one of the tumor sections. So we can see it from here. There's clearly two types of morphology. In the right side, like there's some glandular, crowded glands, looks smooth luminal border, but they're very crowded. They don't really reaching the point like forming cribriform gland, but at this time they're just back to back. And then on the left side of this section, we can see a large area of lesion. At this power, we're not sure this is just part of the normal stroma, endometrial stroma, or is part of a lesion. But we can start to see some cracks in the tumor cells. And there looks kind of discohesive from this power field. But we need to see the cytology to determine is this malignant or is not malignant. Then further zooming of the glandular area, we can see this glands become like convoluted, they're back to back, but the cytology is not like high grade like the serous carcinoma I showed before. Then let's see the other areas of morphology. So these cells, like they're small to intermediate size. They're kind of discohesive and relatively uniform size, arranged in a sheath pattern without any obvious nest or trabecular architecture. But at this point, this could be anything, either lymphoma, plasmacytoma, or high-grade ESS. You're not sure like if it's carcinoma or not. Because there's no architecture, there's no glandular formation to support you with that. But we can appreciate the cell are malignant. Further zooming, like the cells have some nucleoli, they're vesicular, they're kind of irregular, but they don't form a particular pattern. The only thing that makes you strikingly obvious is like some of the cells are quite discohesive. They're not connecting to each other that much. So let's open poll 4. So with this, what's your impression? It's a serous carcinoma, it's a FIGO grade 3 endometrial carcinoma, it's a mixed carcinoma of serous and endometrioid, it's a dedifferentiated carcinoma. So I'll give you guys a minute or two to think about it, and then I will review the immunos, what we did, and how we interpreted this.
I like this case because the morphology is pretty classic for the entity being presented, where you see two different components of the same tumor. It's like a biphasic look to it, right? With a glandular component resembling a typical endometrioid, even low-grade endometrioid, and a solid component showing those discohesive cells with no apparent cell lineage differentiation. And of course, I already see Alim was saying it's a D-diff carcinoma, so show us the immunos.
Excellent. Excellent. This is, yeah, indeed, a classic morphology of dedifferentiated carcinoma. And the immunos actually also support this. So for the glandular area, uh, the tumors are positive, diffusely positive for pancreatin, positive E-cadherin, the membranous E-cadherin, Paxate is positive. But in the solid area, the keratin is very patchy, Paxate very, very patchy and focal, and E-cadherin loss. And both of the areas shows like P10 and PAX2 loss and normal expression of beta-catenin and P53 is wild type. So basically, the final diagnosis is a dedifferentiated carcinoma of uterine corpus. So important part of the dedifferentiated carcinoma and undifferentiated carcinoma. Basically, for the diagnosis criteria for dedifferentiation, it's a you have an undifferentiated morphology, like those solid area, mixed with a differentiated component. Usually, it's a low-grade endometrioid part. But if you're only seeing those undifferentiated solid area, you can say this is undifferentiated carcinoma. So usually you will see a abrupt transition or like clear demarcation of this endometrioid morphology and this solid undifferentiated morphology. Like this two picture like illustrate like low grade component, the solid area, low grade component, solid area, and within the solid area, if you're staring at the morphology, you won't have any idea. This is basically can be anything, like not even carcinoma. So we need to do some st stains, at least some positivity for the epithelial marker, CK8/18, EMA, pancreatin, to justify this is a carcinoma. But diffuse positivity should not be present. You should be thinking about other things if you have diffuse expression of keratin, EMA, CK8/18. So usually Paxate is negative and ER/PR is also negative. And 1/3 of the case can show BRG1, which is marker CA4 loss. So that's a summary of a dedifferentiated carcinoma, and let's get to see case 5. So it's a 50-year-old female with a uterine mass. H&E section, this is a more zooming picture. Oh, let's see. Oh, yeah. Yeah, thank you. Thank you, Alim. Okay, so for this case, this is a kind of a zooming picture of this tumor, but you can see some glandular formation, but they're not like smooth luminal. They're kind of irregular, slit-like. And at the right part of this session, we can see this tumor being very infiltrative to the myometrium. And there's some possible solid or coarse area. Then zooming of the tumor cells, we can see like the cells are relatively monotonous. They're small. There's not much mitosis. There's some glandular morphology and this more solid morphology. And there are some nucleolus, but that's not conspicuous. Further zooming of the area shows the cells basically they're monotonous. They're very ugly. They're not significantly pleomorphic. Then there's the other area of this tumor section shows kind of different morphology. They're start to showing some clear cytoplasm, but the nucleus is still quite small, and they're forming this. This might be a net, this might be a gland. So zooming of these areas, we can just appreciate it like this nucleus is small, monotonous. They're not very strikingly atypia. So basically, we have a mix or ambiguous morphology of the architecture, and the cytology is not very high grade. Then with that, before looking at the immunostains, let's look at the profile. So with this morphology, what's your impression and what are the possibilities? A, it's a serous carcinoma. B, it's a FIGO grade 3 endometrioid. C, it's a mixed serous and endometrioid. D, it's a Mesonephric-like anal carcinoma. E, it's a dedifferentiated carcinoma. If I can pull up the chat box.
I personally would like to see immunos.
I agree. It's not straightforward as well.
Alemus, I can't say
Yeah.
anything.
I can't say anything. Yeah. Yeah, that's the right. Yeah,
That's
that's the right
the right answer.
reaction. This is not something for morphology, like you can say, oh, this is this. It, yeah, we need to see the immunostains. And in real practice, yeah, true. So basically, but with this looking, we can, I personally think we would still won't favor serous carcinoma because the nuclear are not that ugly for serous carcinoma. For endometrioid, that's possible. Mixed ND, Mesonephric-like adenocarcinoma, that's definitely a consideration because before looking at stains, Mesonephric-like adenocarcinoma can look like anything. They have many morphology, many patterns. And for differentiated carcinoma, that's also possible because in the last area, the cells can be kind of discohesive and they're bland looking and they're small.
Yeah, so the idea here, the main point is to just, for example, with the mesonephric, like you have to think about it, think that it exists and include the stains in your panel. You're gonna talk about the stains in mesonephric, so I'm not gonna spoil it right now, but the idea is generally if you're not gonna diagnose anything if you don't think about it, think that it exists, you know?
True. So let's look at the immunoprofile. So basically, the tumor show patchy but unequivocal expression of PAX8, GATA3, and TDF1. The tumor cells are negative for ER and PR. So this is a diagnosis or immunoprofile of Mesonephric-like anal carcinoma, and there are several things. So the things can be helpful with GATA3 and TDF1, and usually they are kind of reverse expression. For example, you have a strong GATA3, you might have a very weak or negative TDF1, or vice versa. And the Mesonephric-like adenocarcinoma always negative for ER and PR. That's a helpful clue. So if you have an endometrioid carcinoma and it's negative for ER and PR, the two classic possibilities. This is endometrial, sorry, this is a endocervical adenocarcinoma, or it's a Mesonephric-like adenocarcinoma, or if it's a high-grade serous that can be negative for ER and PR. Another stain like people use is CD10, like it shows luminal stains, but we didn't do that in this case.
Actually, in the uterus, I think mesonephric-like adenocarcinoma compared to the mesonephric adenocarcinoma of the cervix may show some estrogen receptor positivity. So it's usually described as negative and it's usually negative, but compared to the mesonephric, cervical mesonephric, it may show some ER staining. Focal, weak,
Good
but
to
it
know.
may. Yeah, and CD10 is not that good as it is in the cervix. It doesn't have that good of a sensitivity and specificity in the uterus.
Cool, good to know. So basically, with this immunoprofile, this case was diagnosed as Mesonephric-like adenocarcinoma of endometrium. And for this tumor, it's not actually the classic morphology, and I'm gonna show a classic morphology of Mesonephric-like adenocarcinoma, but this one is from the ovary. So this is a low power field of this Mesonephric-like. Oh, before that, I should clarify one thing. So for cervix, uh, it's called Mesonephric adenocarcinoma. But if you are in a uterus or in the ovary, it's called Mesonephric-like adenocarcinoma. It's just a nomenclature things. So this low power field of this ovarian lesion, we can see like it's pretty infiltrative and low power, it looks bluer. It's like very blue tumor, and they have a mixed pattern of glandular, uh, like this is maybe I think the next picture would be better to illustrate the classic morphology. So basically, you have this glandular, smooth luminal border. Some may be forming, uh, might be forming creviforming, but the nuclear are pretty blue. And this is a picture of the low-grade endometrioid adenocarcinoma. But then further sections, we start to see the nuclear become very stratified and very high in ratio. That's part of the reason makes it looks bluer in low power field. And we start to see some possible luminal pink secretions. That's a soft clue, like, oh, this might be a Mesonephric-like carcinoma. This is FIGO1 endometrioid morphology. Then you just threw some markers and then that confirm this is Mesonephric-like adenocarcinoma. But again, Mesonephric-like carcinoma can have different morphology, different pattern, which can be a really a diagnostic pitfall. So like Miruna said, you have to really know its existence before capturing it. And it's supposed to be have very poor prognosis compared to just your conventional low-grade endometrioid adenocarcinoma. So with that, let's look at the last case, which is the Bonner's case. It's a 70-year-old female with abnormal uterine bleeding and endometrial thickening, but there's no endocervical lesion was found. So with that, let's look at the H&E. This is one of the sections of the endometrium. So we see some large glands with kind of voluminous or possible mucinous cytoplasm, and they are not forming like closely packed gland. They are not forming solid area. They're just kind of this gland. So further zooming of the gland, the cells kind of pencilated, like stratified, and they're forming some connected glands with this clear mucinous differentiation on the apical border, cytoplasm. But with that in the stroma, this kind of peculiar looking in the endometrial stroma, then further we find this area. So before that, we are not even sure this is a benign mucinous differentiation metaplasia or is this malignant or it's from somewhere else. But the next picture shows that this mucinous glands, they have significantly pleomorphism on the cytology on the nuclei. And we can see some possible goblet cell or not that so strong. But I guess let's say this looks like goblet cell. It's grayish mucin compared to the clear mucin of some, maybe the foveolar. But we can get the idea this is a malignant at this point because the significant malignant cytological tibia. Then further zooming of the tumor just to show this mucinous differentiation and the pleomorphism. Then the other section of the tumor, this is a part of this peculiar gland with mucin, and then compared to the background endometrium, this like fluffy looking with some mucinous appearance, but not so. Basically, they're not the same as this mucinous here. So further comparison of this morphology, this is mucinous differentiation had this kind of most like have cilia on the surface and they're quite columnar. But the cell again, they become very vesicular. We can see some mitosis and some might be hyperchromasia compared to this more bland, round oval cells without a clear mucinous differentiation. So then we are in the struggle of, okay, we know this is malignant, but where it's from, what's the type? We need to do immunostain workups. So the first thing we do is CK7, which is completely or strongly positive, membranous positive in this gland, but they're negative in those glands, like we saw this might be endometrial with mucinous differentiation or some metaplastic change in the endometrium glands. Also, I don't have a CDX2, but let's see, the CDX2 is strongly nucleus positive in this glands as well. And here's the CK7. So CK7 is negative or it's patchy in this atypical or malignant gland compared to the surface glands of the endometrium, which is strongly positive. Further things, the ER is deadly negative in this gland. P16 is strongly expressed in this gland compared to the focal or patchy in those uh, background endometrial glands. P53 is also abnormal expression, diffuse expression in this gland with mucinous differentiation or with mucin. Then the PAX8 is deadly negative in this gland. This is just some lymphocytes that shows background. PAX8 is positive. So with all this morphology and immunoprofiles, so what's your impression on this tumor? A is endometrial carcinoma, B is endocervical adenocarcinoma, is HPV related, or it's a gastric type endocervical adenocarcinoma, or it could be an endometrial carcinoma with some mucinous differentiation, or it's metastatic from somewhere else. E, it's a mucinous adenocarcinoma of gastrointestinal type. So this is quite a tricky case. Let's see. So I'm seeing Adam said it's B. Okay, that's a very good differential here. And actually added the option B and C because I think it's very important in this case. So, okay, so let's discuss about all the options. Basically, we have a tumor with clear-cut mucinous differentiation with possible goblet cells, and their expression CDX2, CK20, negative CK7. So they have clearly gastrointestinal immunophenotype. So the differential could be this is a metastatic from GI. We get that out because we have no history. And there we assume this lesion is primarily in the uterus. And for the option B, HPV-related endocervical adenocarcinoma, because we see this P16, that's definitely a possibility. But the thing that's peculiar on this one is if you have HPV-related endocervical adenocarcinoma, you won't have strong CK20, sorry, yes, CK20 and CDX2. You won't have this expression. And also, I think P53 abnormal is very unusual in this scenario. And I'm not sure we did like P16, sorry, HPV-ish on this tumor, but we know this tumor is primarily in the endometrium, not in the endocervical. That is very important. So for example, if you have endocervical lesion in this case, it's quite tricky. You need to confirm, do HPV-ish. This is not from endocervical. So the final diagnosis we have, this is mucinous adenocarcinoma of gastrointestinal type. And so let's talk about other differentials first. So, oh, do we have any question? Oh, thank you. All right, so the first differential we definitely want to rule out in primarily in the endometrial is endometrial carcinoma with mucinous differentiation. So by definition, in WHO fourth edition, the previous edition, it is defined as tumor with more than 50% of cell containing mucin. But now in the newest edition, it's now recognized that endometrial carcinoma with mucinous differentiation regardless of percentage. If anything, you saw any mucinous differentiation, that you can call it. But importantly, immunophenotypically, you won't have the gastric or gastrointestinal phenotype, like CDX2, CK20, MUC6. MUC6 is like a caloric marker for gastric. So basically, if you do the immunostains for endometrial carcinomas mucinous differentiation, you will only have CK7 positive, CDX2, CK20, MUC6 all negative or deadly negative. Uh, Sorry, I think there's something I want to add. So if you have negative ER, Pax8, and negative CK7, uh, with that immunoprofile, you will much more favor endocervical adenocarcinoma. And in this case, the negative ER, positive P16, it indeed raises the possibility of HPV-related endocervical adenocarcinoma. But it's again, it's unusual to have CDX2, CK20 phenotype, and also the mucinous morphology with goblet cell. And to make things much complicated further, there's a gastric type of endocervical adenocarcinoma, for which like you won't see a strong P16. And those type of cancer are like, I think in this case, it's important to know this is the cancer is in endometrium, not in the cervix. So let's talk about the diagnosis here. This is a very rare type of primary endometrial carcinoma. It's called mucinous carcinoma of gastric or gastrointestinal type. So it's more clinically aggressive than a conventional endometrial carcinoma. It's aggressive histotype per FIGO 3. Uh, per FIGO staging. And gastric type morphology defined by you have pyloric type or hypermucinous morphology. If you have intestinal morphology, basically defined by presence of goblet cells. And very important, we need to do immunostains, and usually they show diffuse strong positive for CDX2, CK20, MUC6, those gastric or gastrointestinal immunostains. So basically, this case was diagnosed as this. And last, I'm just gonna briefly touch on the molecular classification and importantly, the associated histological features. So, as we all know, like right now we have four types of molecular classification. The poly ultramutated endometrial carcinoma, the histologically this often high grade ambiguous morphology with scattered tumor giant cell. They can have prominent TILs. And for MMR deficient endometrial carcinoma, they are high grade, prominent TILs, mucinous differentiation, MELF, but those are not very characteristic. And for P53 mutated endometrial carcinoma, as we showed, it's mostly high grade with diffuse cytologic atypia. That's a pitfall you are thinking, oh, this is a high grade endometrioid or this is a serous carcinoma. That's usually have a P53 mutation. And then the last type is an SMP. Basically, you don't have P53, you don't have MMR, you don't have poly. The other categories, they can have some 30 to 40% with CTNB1 mutation, and they are mostly low grade with frequent squamous differentiation or morals, absence of TILs. And with that, I think this covers my entire topic, entire talk. I just want to let us to discuss and to learn the classic and to see the unusual things. And thank you for your attention. I'm happy to take any questions or any comments.
I would just like to add regarding the Mesonephric-like, being called Mesonephric-like in the uterus and ovary and Mesonephric in the cervix. The nomenclature is used to reflect the fact that in Mesonephric-like, although there is some sort of Mesonephric transdifferentiation or differentiation of the tumor, it is essentially, or this histogenesis, it's not clear as of yet, but it seems to be of Mullerian origin. It has even the molecular profile, it has molecular abnormalities that are common to both mesonephric adenocarcinomas like KRAS and RAS mutations, but also of Mullerian carcinomas, the PIK3CA, the ARID1A, PTEN. So that is why also Mesonephric-like adenocarcinoma in the ovary and even in extraovarian sites, but that rarely, is associated with endometriosis and also stands to its Mullerian origin. So that's why it's called Mesonephric-like and not just that we have an explanation for the terminology, because otherwise it's may be difficult to remember why is it called. It's not arbitrary. That's what I'm trying to say.
That's a good point, Miruna. Thank you.
Yeah, I always like to attach explanations to stuff that I have to remember because otherwise I cannot remember them.
True, true. And touches also. Yeah. All right.
Yeah, so if there aren't any questions, um, I think we can end this here. Thank you so much, Jackson. The cases were very, very interesting. And I hope you guys enjoyed it. And
Thank you,
I hope
guys.
to thank you, Ademo. Thank you for being here. I hope to see you guys again. Um, maybe somebody else would like to volunteer to present. I'm planning on presenting the second part of my pink renal tumors. I've been working on that sometime in December, I hope before the holidays. Yeah, and until then, we'll see each other on Twitter.
Yeah. Thank you.
All right. See
Thank
everyone.
you. Thank you. See you.
Have a good one. Bye, guys.
Bye bye.